Thanks, Reno. So again, thank you to Dr. Philippon and Smith and Nephew. I'm especially excited about this topic. Very complex, but something I like to talk about. I'm going to speak about how to approach a failed previous hip arthroscopy, specifically looking at labral reconstruction. Disclosures, again, no bearing on the content of this talk. So I get asked a lot, how do I indicate patients for procedures? So what are the indications for revision? I thought about this quite a bit, and I think that the best answer is that the patient's expectations from a previous procedure are not met. And then secondly, there's something objectively that I believe I can considerably improve upon what the patient has already had done. And lastly, the patient wants and needs to do something. So really the focus of this talk is going to be on number two. And this is what I want to try and help you figure out, how I figure out how to indicate a patient and what information I need to gather. So the first thing to start with is to try and assess the original surgery. If you can get a hold of the arthroscopic pictures, again, I'm very visual. I like to see what the cartilage quality is like on both sides of the joint. I want to see what the labrum looked like as well. In your mind, you have to kind of assess, okay, was the procedure performed technically well or not? Are there some areas that can be improved upon? And lastly, and this is a little bit deeper, but this is what you really have to take a look at. Was the original problem just the hip joint, or was it something more? And that is very, very helpful. We just saw a girl in clinic yesterday who's hyperligamentous lax, who's 17. Her original problem was that she had instability of both of her kneecaps. She saw a hip surgeon. She ended up having a hip arthroscopy and an IT band release, thinking that it would help her knees. And now she has painful hips that are more painful than her knees. So it's helpful to kind of spend the time to really figure out what you're getting into. So with the patient evaluation, really want to kind of spend some time with them trying to understand the original pain. One of the questions that I think helps us quite a bit is, did the original surgery help for a period of time? And I'll get into that a little bit later, but I think sometimes when the labrum is stabilized, even if it doesn't heal, for a little bit it might feel better. And then that shows you that the hip was the primary problem. Diagnostic injections, Dr. Wilk talked about that earlier today, very helpful. Was it done before the original index surgery? If so, did it take away 100% of the pain, or did it take away something more? Because I think, we see some patients who are simply just hip problems, but a lot of them have some pelvic floor issues, SI joint issues, lower back issues, sciatic issues, and they're usually a combination of things going on. The evaluation, physical examination, it is very easy to diagnose a bad hip when somebody has had a hip arthroscopy that has not worked, okay? The hip does not move well. It is very easy to make them sore. They're very guarded. They typically still have relatively full range of motion, but anywhere near that impingement position, they are very uncomfortable, much more so than a primary situation. You want to take a look at your x-rays. You want to see if you have any arthritis, but also you want to assess the impingement work that was done prior. Look at your MRI. I think the MRI is helpful, but a lot of times you do have metal artifact from drills and burrs, and so it's not perfect. It's one element. It's not the be-all, end-all. Diagnostic injection in the revision setting, I think, is essential. I use Marcaine and lidocaine only. I do not combine it with the arthrogram. The pressure from the arthrogram, I think what Dr. Wilk said is absolutely true. I think that that can offset the benefit that you would have expected to see from the Marcaine and lidocaine. I don't use steroid either, because steroid is simply confusing. I don't know when it's supposed to turn on. Is it 2 days, 3 days? Is it supposed to last for a week, 2 weeks, 1 hour? I don't know. So I like that defined window of the Marcaine and lidocaine, and I like for the patient to have a defined movement or activity that creates their pain. I want them to do that once they've had the block. And it also helps significantly because it sets an appropriate expectation objectively of what I should be able to take away with a successful surgery. Now the next question, what is the main pain generator in a failed previous hip arthroscopy? Okay, I think inside of the joint, not the stuff outside of the joint, the accessory problems, but I think the labrum is still the primary problem. And so what I then ask is, then why did the labral tissue then fail? And so we went through this in the previous talk, but underlying dysplasia, I think, is a big part of this. Residual FAI, incomplete cam and pincer resection. I've said this before. I really truly believe that a lot of people who do hip arthroscopy, their cam and pincer work is an afterthought, and I think it needs to be the primary work. When you look at failure of the labrum, because it can heal, or it can fail in and of itself. If you do a debridement, sometimes you take away some of the hoop strength, so labrum adjacent to where you did your debridement can come loose later. Labral repair, sometimes the tissue just doesn't heal. And I see that more commonly in these patients. Ehlers-Danlos, they're very lax, very hypermobile joint. They can beat up their labral repair pretty quick. Inflammatory arthritis, just really inflamed tissue, hard to get to heal. It's usually red when you get in there. Diabetes often get stiff. I never close the capsule, but they also have impairment in their ability to heal. And I think workers' compensation is a real tough patient population because you've got one shot with them. If you don't make it on your first shot, you're going to have a problem later. And then obviously you want to look for arthritis. So perfecting your FI work, I know I've said this, you really have got to spend the time to take this to get to this. And then for your CAM, it is possible to make normal looking hips, but they take a lot of work. Next question, what are the proper films to take a look at? Well, this is an example of a patient who had failed a previous hip arthroscopy. And the surgeon that had done this work uses a done lateral, and you can see this is the pre-op, this is the post-op. I think everybody in this room would say, oh, that looks really good. Okay? But when you take a look at it with what I use, the cross-table lateral film, you can see this is the same patient. So the two are not equal, right? This is an over-resection. This is medially based. Dr. Philippon is going to talk about this. This is a big problem, okay? And it's not salvageable. And so I think we really have to refine the films that we use, both evaluating what we're going to do preoperatively, but also what we've done postoperatively to make sure that we're doing what we think that we are doing. This is a case of residual CAM, so this is also another situation where probably a done lateral was used. You can see they did work over the top, but they didn't come down over the front. So you can see all of the residual CAM through here. And then when you come under, you can see here's the ligament, the ligament of Weibrecht, or the medial synovial fold. So you really have to work between the boundaries of the medial synovial fold and near the vessels. And this one probably even got close to the vessels. You can see we've revised the femoral osteoplasty. Bone's a little bit soft here, but we've got a more appropriate shape, and we burred the acetabular rim in preparation for our labral graft. But this is a little bit more thorough now and goes appropriately down to the bottom part of the femoral neck. Next question, what about just a failure of the labral tissue to heal in and of itself, even in the presence of good FAI work or the absence of dysplasia? Well, I think when we take a look at our current repair technique, I really think that it certainly could be flawed. When we take a look at the cross-section, you can see here's the femoral head, here's the acetabular rim. You can see cartilage coming around on the cup and coming into the triangular labrum. Virtually 100% of our blood supply is on the capsular side, and the first step in a labral repair is to take this down, expose the acetabular rim, burr the acetabular rim, and then repair it back down with an anchor. So compromising a relatively tenuous blood supply may not be a perfect solution for labral repairs. Also, when you take a look at a labrum like this is a mildly anteverted cup, not enough to generate any interest in a PAO, but you could see a massively hypertrophic, really disgusting, bad labrum that's very painful. And this is the situation, going back to what I said earlier, that maybe if you repair this, you might get a couple months where they feel pretty good. But I don't think that this tissue is going to be stabilized forever. One of the tenets of orthopedic trauma always was it's a race between tissue incorporation or healing versus implant failure. And I think you'll overcycle your sutures at some point because probably this won't heal. Mattress sutures, we hear a lot about this. I've taken out a lot of labrums, and I guess you just have to trust me, but the labrum is really like a marshmallow. It's hard on the outside and it's soft in the center. And so I've revised a lot of patients that have had a mattress suture type of repair. And I think what happens, it happens blind. You can't see this, but when you suture down and tie down that suture, it scissors down through that tissue significantly. And virtually every mattress suture that we have revised, we've barely been able to fit a 1 millimeter diameter probe through there. So I think the thought process is to get a seal, but you have to remember that your primary goal in repairing a labrum is to get the tissue to heal. And I think the circumferential suture is stabilizing first, and if you put your anchor in a good place, you can always have a seal with a well-placed anchor. The tools we have for revision, labral reconstruction, I want to go through. I think that should be part of your armamentarium for sure if you want to take on these patients. Revision of the cam and pincer, Gons osteotomy. Femoral osteotomy, I put a question mark there. I think there's a lot more interest in this today, but I've been looking at MRIs for the last year or so, looking at anteversion. Honestly, I do not think that there is a defined small, narrow margin of what is normal. But I think that version is being blamed as a problem for labral failures. I think that this may have an indication, but I think it's more narrow than it might be for some people in the future. Total hip replacement. Unfortunately, we have to consider this. We have to be able to do this procedure, or have to have someone who can do it for us or with us if it's necessary for the patient. Because taking on a revision is a big responsibility. These patients are suffering much more than a primary labral repair, and you really have to put an excellent foot forward to try and get them out of a very bad position. So now we're in the operating room. How would you address this tissue? Because all of you want to do revision procedures. What would you do in this situation? This is a 26-year-old physical therapist. He had a 5-anchor labral repair. You can see the classic scarring that occurs that's matted down between the labral tissue and the capsule. And so how would you address this? He's got a healthy joint otherwise, and he's 26 years old. So in my experience, between 2008 and 2010, I performed a lysis of adhesions to remove all those adhesions. I touched up the bony work to try and refine my cam and pincer work as I evolved over the years, and I re-repaired the labrum. I stopped doing this because my database showed me, and also my subjective experience showed me, that my failure rate was too unacceptably high, and all these patients have names. I know every single one of them, and it broke my heart when they failed again. So I changed. I went to the reconstruction in 2010, and I've been happy with the change, but I wanted to look at this, and I wanted to see why we were seeing the benefit that we were. And I thought in the clinic, with the reconstruction, we started seeing a better restoration of pain-free range of motion. And I think over the years I've tried to figure out what my responsibility is in my role of taking care of patients. And I think physical therapists are absolutely essential to get a good result with these patients, because by the time they failed 1, 2, 3, 4 surgeries and you're doing another revision on them, they've built up pelvic floor issues, SI joint issues, gluteus medius issues, and they have a lot going on. And our role is to get pain-free, smooth range of motion. Take the joint out of the equation so they can work on the soft tissues. And I was more able to do this with the reconstruction than anything else. It worked in very complex multiple revisions. About a year ago, we operated on a 22-year-old that had had 5 previous hip arthroscopies before she traveled to Denver. And so it works in even the most complex. I think the reason is because it's an aneural graft, and I think also you can restore normal anatomy. And the nice thing is that it's a definitive procedure, not to kind of jump on those older patients that we were talking about earlier. But I think older patients can do well, especially if we give them a definitive procedure, because I think the problem is if we repair a 55-year-old labrum and it's degenerative, if it doesn't heal, then we sit down at 57 and you say, all right, do we do a total hip now, or do you still have a perfectly clean joint? Do we do a revision? I like this because it's definitive. This was the paper that we published in December, Revision Arthroscopic Acetabular Labral Treatment, Repair, or Reconstruct. To break it down and take a look at it, we had 15 patients in the re-repair group, 98 in the reconstruction group, which is a huge cohort for revision procedures. 1 was lost to follow-up in the re-repair group, 8 in the reconstruction group. So final follow-up was above 90%. The average age, 28 in the re-repair group, 34 in the reconstruction group. So already, this is a harder patient population to work with, right? Gender distribution was about the same. The range of follow-up was different, 2 to 6 years versus 2 to 5 years, average 4.7 versus 2.4. Now that's a problem with the study, but you have to remember that this is reflective of my practice. In 2010, I simply stopped doing re-repairs, okay? I'll show you why they're comparable in the next few slides. When you look at the results in the patients who did not fail, okay? You can see we look at Harris Hip score, lower extremity functional score, which is an excellent score. It's really quick and dirty, but shows you how well the patient is functioning athletically. The VAS pain score, level of satisfaction. You can see improvements of 28 and 32 when the procedure works well, 21 and 25 for the lower extremity functional score, pain reduction of 3.5 versus 2.8, and an overall very satisfied patient in both groups. So a trend towards better results in the reconstruction, but it was not statistically significant. When you look at the failures, though, this was 7 of the 14 re-repairs failed, 11 of the 90 reconstructions failed. Now, the reason why we felt we could compare these is that the majority of the failures, as we saw in the literature, occurred before 2 years. So as all of our follow-up was over 2 years, we felt that we could compare these two groups, showing a final failure rate of 50%, which is unacceptable for these patients that are really suffering, versus 12%. So we concluded from this that revision labral repair was 4.1 times more likely to fail than labral reconstruction. I also was able to compare within this the segmental grafts versus the longer grafts, and we had better results in the longer grafts. Final Harris Hip score improvement, again, was 32. So again, same slide I showed earlier, but you can see really massive correction with regard to the quality of what is inherent in the joint with your reconstruction. Now, how do you do this? So this is the technical pearl. If you're going to do labral reconstructions, if you're going to do high-end repairs, you have to learn how to do central compartment work in the peripheral compartment. Okay? You have to be able to work on this when you are in the peripheral compartment. I want to back up because I want to really emphasize that point. I'm going to go back to that picture one more time, because that's the only way that you can work on the anterior aspect of the cup. Otherwise, you get crossing your instruments. It's too hard to get down low. It's too hard to get perpendicular on the bone. And especially in this situation, if you start working on this central compartment, you're going to take out all of your capsule, and you're really going to beat up all the soft tissues around the joint, and you're not going to have an envelope to work in. And to be able to do a reconstruction, you have to have capsule intact, and we've been talking about the values of the capsule already. So what you do is you flex up the joint. You start from known, which is at the bottom part of the cup where there's never any scarring, and you dissect into the unknown, that dense, nasty scar, and it is very thick. You need a cautery device. You can feel the acetabular rim as you're doing this. Okay, you're looking upside down. Okay, and then you're dissecting through that capsule tissue. And you can see you preserve the capsule, you get down to the rim, and now you can take out the labrum. So now you've removed the labrum, you've gently excoriated the edge of the acetabulum, because you can see he's a little bit hypoplastic with his anterior inferior wall. You have some residual suture that's grown into bone. You try and get everything out and clean it up, but you can see that capsule there is still intact. And now you can see you've come all the way across through all that nasty scar, and you've got the rim preserved. Okay? There's your reconstruction when you reduce the joint, and that's how you get the reconstruction done. But you have to learn how to work in the peripheral compartment for the anterior aspect of the cup for the central compartment. So putting it all together, for me, for sure, labral reconstruction far more successful than labral re-repair in the revision setting. I can't emphasize enough, if you're going to take on revisions, okay, you have to decide what you want to do and what you don't want to do. If you just want to do scopes, that's fine. But you have to have someone around you who can do a Gons osteotomy, can do a femoral osteotomy, can do total hip replacements, because you're not quite sure what you have to add in. But you can't keep doing the same thing over and over again and expect a different result. Don't ignore the dysplasia if it's there. Don't ignore the arthritis if it's there. Do the definitive procedure for the patient so you can set a definitive final procedure. Set realistic expectations for your patients. Now, that doesn't mean saying, look, I don't think you're going to get a good result from this. I think that we have to be honest with patients when that may be the situation. But then it's our responsibility to find a better procedure for them. I think the main thing in setting those expectations is say, you know what, you're a little bit behind the 8 ball. You're coming in with a little bit more baggage. We've got a lot of work to do with the physical therapist. We need to set you up with a perfect physical therapist for you who understands it. If you have pelvic floor issues, we need to get you involved with a pelvic floor therapist as well. We need to have a team around you so you can have a good result. And I think that expectation from what our surgery should gain comes from a diagnostic injection as well. So I would always encourage you to do that. These are rarely going to be home run 100% improvement injections. They're usually somewhere between 60 to 80%, but the patient then understands what pain is coming from where. Make sure you have awesome physical therapists to work with. I cannot emphasize their value and their overall care of patients. So find a team around you. If you guys are interested, please come visit. We have training opportunities through Smith & Nephew, and if the videos were helpful for you today, Joint Media Solutions can help tie them together for you. Thank you.